identify calcium scoring in the coronary arteries. It is now available and it seems to correlate well with the presence or absence of coronary artery disease in general or in diabetic patients. If we're going to do a stress test, exercise stress test is preferred because the response to exercise itself has a prognostic value. People who cannot do exercise stress tests, we do pharmacological stress tests for them. Now, neuropathy. Neuropathy comes in all different shapes in diabetes. They have sensory, motor, autonomic, and we screen patient for them, try to prevent them. The prevention of it is no difference from preventing nephropathy or retinopathy. It's still good glycemic control, controlled blood pressure, and high cholesterol lowering agents. So diabetic polyneuropathy is primarily a symmetrical sensory neuropathy that initially affecting the distal lower extremities. You all hear about the gloves and socks and gloves. And the second thing, they lose the vibratory sensation and altered proprioception, and that's large fiber loss. And then, of course, they have impairment of pain to light touch, temperature, which is secondary to a loss of small fibers, and should be suspected in any patient with type 1 diabetes for more than 5 years and in all type 2 diabetics, because as I mentioned before, people when they get diagnosed to be type 2 diabetic, they already had at least 5 years back, they were pre-diabetics, and things start in that stage. So by the time of diagnosis, they already had established some form of complication, microvascular and macrovascular. We should screen all patients for neuropathy of at the diagnosis of type 2s and 5 years after the diagnosis of type 1s. After the initial screening, all of them should be, the screen for neuropathy should be done annually. As you all know, diabetics, we examine their feet, we check them, we do vibration, we sensation and ankle reflex and all of that. And as I said, pinprint, temperature, vibration, we can use this in clinical office. The other one, which is less, not less, we have less awareness of, or patient don't know, everybody talks about my hands, my feet, it burns, but there is a very serious and very important entity, is the autonomic neuropathy. Autonomic nervous system supply all the internal organs from heart, gut, everywhere. Everything inside the body is supplied by the autonomic nervous system, including also the sweat glands and things we don't think about. But poor glucose control and vascular risk factors appear to be, they are very tightly associated with each other. And it is a serious, and usually in advanced cases of diabetes, especially that are poorly controlled. Intensive therapy probably is the most important and the only thing respect to autonomic neuropathy lead to significantly lowering the rate of progression of the disease. In contrast, there was no slowing in the peripheral neuropathy. It's very important for that specific form of neuropathy. The ADA recommending for diabetes neuropathy at the time of the diagnosis, we have to kind of screen them, and the same thing 5 years after that for the type 1s. There's some tests because it affects the internal organ, heart rate gets affected, gut, people complain of diarrhea. It's not maybe from the medications they're taking, but actually from the damage to the gut nerves. So test of heart rate variability may be indicating, including expiration, inspiration, they change in the vagal stimulation or suppression, response to Valsalva maneuver or to standing. Many people complain by standing, they feel dizzy. This is all has to be checked, and it's usually late in the disease. If it's negative, if the screening negative, we continue to screen annually. I did mention smoking. This is just completion of the prevention of the diabetes complication. Smoking by itself had much greater, I just wanted to say that because I was surprised to read this, had a much greater benefit on survival than most of the other interventions. So stopping smoking is kind of high on the list, high position on the list. Now I'm going to talk about using aspirin in diabetics. Aspirin trials in patients with diabetes does not show a significant benefit of aspirin for the primary prevention of cardiovascular effect. Although there were a couple of studies, one Japanese study and another EDDRS, it's a cardiology study, showed some benefit, which I'm going to talk in detail. Aspirin 75 to 162 milligram per day is recommended for secondary. See, the primary is not recommended, meaning if you don't have a cardiovascular effect thing or high risk, you don't use it. But it's only used for secondary prevention in diabetic patient with a history of myocardial infarction and other established cardiovascular disease like peripheral vascular disease, cerebrovascular accident, something that established. Aspirin 75 to 162 is recommended for primary in any patient at an increased cardiovascular risk if they have a 10-year risk of 10%. Most primary care physician and us, we have a kind of a scoring system to see if somebody is at 10-year risk. They are more than 10%, some of them up to 20%. Diabetes by itself is almost there. So, but the evidence, many of us do that, but the evidence to support this recommendation is really weak. Aspirin is not recommended for diabetic patient under the age of 30 due to the lack of evidence of benefit, and is contraindicated under the age of 21 because of the Rett syndrome, which is it's in the liver failure. Plavix 75 milligram is recommended for patients with cardiovascular disease and documented aspirin allergy. So basically, primary, no. Secondary, established coronary artery things, heart attacks, strokes, Many of us, as many diabetics are on aspirin, they take it even sometimes. Most of my patients come say, I'm taking aspirin. But if you really want to match the criteria, they don't fit the criteria. They are maybe high risk. Diabetes is a high risk, but there's the evidence are weak. I don't know. I've seen a lot of complications from aspirin to advocate it freely to people, even with high risk. There's a lot of bleeding problems from it, and transfusions and anemia and all kinds of things for people who have issues with the gastrointestinal tract. So very careful. And also, if somebody has a high blood pressure, and I've seen it too, they have hemorrhagic strokes like that. So, you know, it's a very fine line. You have to have good indication to use it, and also you don't have any risk factors for bleeding in order for you to be using it. So this is just to show that intensive therapy of diabetes is by far much better, you know, much better on effect on microvascular disease. And the same thing for blood pressure, the better control of blood pressure, the tight control is better on, you know, for everything, retinopathy and especially heart. Okay, now we're going to talk, after we talked about the prevention and all, we can use that phase, we can intervene, do primary prevention, prevent people from developing diabetes and or preventing the progression of complications. Now I'm going to touch on some of the new medications that came to the market in the last 1 year, and remind you of the other groups. Of course, you know, it's part of the diabetes management is education, and we just mentioned how to evaluate for the micro, the macro. You normalize glycemic control, which I'm going to talk about right now, and we minimize all the risk. And we also have to, and recently the FDA has been very much aware that all the medication that will be approved for diabetes must not allow for, it shouldn't cause, you know, complication and particularly weight gain. And the joke was the other day, if they, you know, the insulin would never have passed. But because now it's very important, it was found that any medicine that causes weight gain, regardless of its effect on sugar, is not good for diabetics. So this is becoming a very important thing. So we really have to we have to come up with medications that does not aggravate the abnormalities of insulin and lipid metabolism, like what happened with the thioglitazones like Avandia. This is kind of traditional, I've had this for 3 years, this traditional step, everybody kind of agree on this, the stepwise management of diabetes. We start with lifestyle modification, we talked about, and also we start with monotherapy, combination therapy, and we keep adding on. We target different, I call it different pieces of the pie. Diabetes is a multifactorial. It's not only the pancreas, it's insulin resistant, it's appetite suppression, there's a lot of things, glucagon secretion, all kinds of, it's multifactorial disease, and therefore now it's not insulin anymore. It used to be, insulin is the available drug of choice. Now there are multiple drugs that target different areas in the treatment of diabetes, and hopefully the goal is to prevent weight gain that comes with these medications. So this is where we're heading. This is just to show that how modest is oral therapy in the management of diabetes. They all contribute. You see the reduction in hemoglobin A1C, that only metformin up to 2%, but the rest are all like less than 1%. And when we see diabetics sometimes 12 and 13 and 14% hemoglobin A1C, that just shows you that it's impossible to control diabetes with monotherapy, really, especially if it's advanced. And the UK PDS trial has proved that usually a combination therapy is better even at the start of managing diabetes. So this is what I was just talking about, the sites of actions. Diabetes is multifactorial. All these medication may work on the pancreas, may work on the liver, may work on the gut and the muscle, and collectively and together they will achieve normal glycemia, which is the goal in management. And therefore we choose, and as you see all these names of the medications, we use different. We use metformin to work on the muscle, and we help it also, it works on the liver, and nobody knows where metformin works, but it can work on different places to improve sensitization. But also we use a secretagogue like sulfonylurea in combination with metformin to improve insulin secretion, and both target two problems well known to happen in type 2 diabetics, which is the insulin is insufficiency or deficiency, and the insulin resistant. This is the ABC of diabetes management. This is an it's also one of those very old, well-known table. These are the goals, and there's an asterisk at below 7. Most of the ACE, for example, recommends 6.5. We also go all the way down to normal in patient using only oral medications. There are some studies showed that using insulin maybe in an older population, we have to be very careful, and the management of older population is different from younger population. I just wanted to mention about insulin. I'm just going to kind of skim through. It's the whole idea of using insulin therapy at this time is mimicking physiology. We have to have our pancreas gives us a basal insulin, and every time we eat, it gives us a few units of insulin to cover our meals. So basically, the idea of using insulin is to mimic physiology. We have the long-acting insulin and we have the short-acting insulin. The long-acting is to give us a basal, and the short-acting is to